Good evening and welcome to our Waltham Public Library program, Wastewater Testing for COVID-19. My name is Deborah Hoffman and I organize programs and events for the library. Thanks for tuning in. Before we start, I want to let you know how the evening will go. We have two presenters who will speak for about 30 or 40 minutes and then they'll field questions. To ask questions via the chat function, use a Google account to sign into YouTube, and feel free to write your questions at any time, and then I'll read them at the end of the presentation. Newsha Ghaeli is president and co-founder of Biobot Analytics. Prior to Biobot, she was on fellowship at MIT, where she was project lead at the Sensible City Laboratory and instructor in the Department of Urban Studies and Planning. Her work at MIT explored the future of cities and investigated the creative application of sensing technologies in urban systems to build responsive, resilient, and efficient cities. Dr. Jonathan Levy is a professor and chair of the Department of Environmental Health at the Boston University School of Public Health. Dr. Levy's research centers on urban environmental exposure and health risk modeling, with an emphasis on spatio-temporal exposure patterns and related environmental justice issues. Over the past 2 years, he has been researching patterns and predictors of COVID-19 in Massachusetts. Thank you both for joining us tonight. Over to you, Newsha.
Great. Well, thank you so much for having me. I'm very much looking forward to talking more about Biobot Analytics and wastewater epidemiology. So let's get started. All right. So as Deborah mentioned, my name is Newsha Ghaeli, and I'm one of two co-founders and president at Biobot Analytics. And Biobot is a wastewater epidemiology company. I'll dive into a little bit what that means exactly, but essentially we are building early warning health analytics from data that's available in our sewers, in our city sewers. Biobot is a spinoff from the Massachusetts Institute of Technology. It was started by myself and my co-founder, Dr. Mariana Matus. We met at MIT as researchers. I was in the Department of Urban Studies and Planning, investigating the future of cities, and Mariana was a PhD student in computational biology and microbiology. And we really came together with this research question of, can we look at our sewer systems as being analogous to the human gut? So in the same way that we can tell a lot about a person by analyzing their microbiome, what can we learn by analyzing sewage in a city? What can we learn about the inhabitants of a city? And how can that information help us be more proactive when it comes to promoting health and actually designing health interventions for our communities? And so inspired by this potential, we started Biobot Analytics in 2017. We are headquartered as a company in Cambridge, Massachusetts. So at Biobot, who are we? Who is the company? Our mission is to transform wastewater infrastructure into public health observatories. That was the mission that we started the company with back in 2017, and it's the mission that we still hold today, 4 years later. And this is really because we believe that sewage offers a unique opportunity to make public health more data-driven. Sewage is an untapped resource, and we really believe that we can build tools and technologies to help transform this latent resource into something actionable for city officials, community leaders, and residents. And so inspired by this potential, we started Biobot, and we were the first company in the world to bring this technology to market and bring it out of academia and make it available to communities to use to tackle public health issues at hand. When we started Biobot in 2017, of course, there was no COVID-19. And so the first application that we started working on was what was the biggest public health crisis up until early 2020 and what still continues today as a major public health issue. But we started our work focused on generating data to help communities better respond to the opioid epidemic. And then in March 2020, we very rapidly expanded our work to implement the capabilities to actually analyze sewage for SARS-CoV-2, the virus that causes the COVID-19 disease, and launched our COVID-19 capabilities very early in the pandemic. Since then, wastewater epidemiology as a field, as well as Biobot as a company, have absolutely exploded. We are now leading in this emerging market of wastewater epi. It's been very exciting to see this technology get the wide adoption that it has and get the exposure that it has. We've been featured in press across the country at the local level, all the way up to the national level, including a fun feature that we did on The Daily Show with Trevor Noah. So if you're curious about some poop jokes, I would highly recommend checking that out. And of course, with that recognition and the value that was demonstrated, we also saw massive growth as a company. And that wide adoption of wastewater epi took us outside of Massachusetts and across the country, where to date, we have worked in all 50 states. We've worked in US territories. We've worked in Canadian provinces. We've also worked in countries in Latin America and South America via a partnership with the World Bank. We have tested almost 20,000 samples to date, and our data is representative of over 30% of the US population at this point. And that maps to approximately 700 sampling locations or communities. So that you get a sense there of how scalable this technology is. With, only hundreds of samples, we have representation of 30% of the US population. And what's interesting to point out is that we've seen adoption of this technology in cities of all sizes. Unlike traditional smart cities technologies that tend to be adopted largely by large, wealthy metropolitan regions, we actually see adoption of wastewater epidemiology across small towns and rural areas to mid-sized cities, all the way up into those large metropolitan regions. So that really demonstrates the versatility and value of this technology. And so we've, been really excited and happy to have been able to establish this platform to enable early warning health analytics to combat pandemics. And a few of the values of wastewater epi that have been established over the last couple years are that, first, it is predictive. So wastewater data is a leading indicator for new infectious disease cases. We've demonstrated that in our data. Other research groups and academic institutions across the country have also corroborated that with their own work. And so it's been demonstrated that wastewater data can be tremendously valuable as a leading indicator in some cases. Second, wastewater data is inclusive. We like to say at Biobot that everybody has a voice in our sewer systems, not just individuals who have health insurance or who access clinical care. So when compared to clinical data or hospitalization data, we know that wastewater data is very inclusive and is representative of everybody in a community. And finally, it's versatile. Wastewater is a rich source of health information, and really anything that is excreted in urine and stool, we can start to look for. So a single sample, that same sample, can be analyzed for COVID-19, but also we can start to look at things like influenza. We can start to layer on tests for other viruses like HCV. We can start to understand the diet and other biomarkers within a community, indicators for things like stress, for example. So just very briefly, how does this work exactly? So you can see on the left, we have a toilet. All of our toilets are connected to our sewer systems. So when when you use the toilet, you're depositing a sample effectively into our sewer system. We then collect sewage either at the manhole level or the wastewater treatment plant level on the far right, you can see. When collecting samples at a wastewater treatment plant, we're looking at data that's representative of an entire community. Wastewater treatment plants tend to represent entire cities, multiple cities, an entire county, or even multiple counties at times, as is the case with the Deer Island wastewater treatment plant that's run by the Massachusetts Water Resource Authority. We can also start to get more granular and pull samples at the manhole level to start to look at parts of a community and actually be able to understand the health of, tens of thousands of people in one region of a city as opposed to the tens of thousands of people in another region. And this starts to get really valuable when officials are leveraging this information to direct resources. For example, let's say testing capacity or mobile testing resources. So I'm going to spend a couple minutes here looking at just the data and actually digging into the data and understanding how this information can really enable local decision making. How can wastewater data actually enable us to take some actions when it comes to public health decision making? So this is a time series that was pulled off of our website from Suffolk County, Massachusetts. This data actually represents more than just Suffolk County. This is data coming from Deer Island in the Boston area, which is one of the largest wastewater treatment plants in the country and represents about 2.2 million people who live in the Boston area. This sewage treatment plant is run by the Massachusetts Water Resource Authority, and they're also posting this data separately on their website. So folks might be familiar with the time series that MWRA is also sharing. So here we're looking at the time series only through mid-January. So this screenshot is taken during the Omicron wave and just as we saw that wave decreasing. And you can see that throughout the course of the pandemic, since we've been working with MWRA since early 2020, the local community in Boston has really engaged with this information. And increasingly over time, it became an essential public health tool as the pandemic evolved. In particular, this past wave that we had over December and January, just a couple months ago, because the community had seen this data mirror and track clinical cases time and time again through previous waves. When the wastewater data shot up in December 2021, there was a strong response from the community in order to actually take some action based on the information. One of the examples of an action taken that I really like to share is one from Boston Children's Hospital. So there was a New York Times article in January of 2022 where the chief medical officer of Boston Children's was talking about how in December 2021, when they saw the virus levels rising in the wastewater data from MWRA, they actually started limiting or postponing non-emergency procedures for the first few months in 2022. So they knew that we were entering into a wave, and operationally, what that meant for the hospital was a potential, large influx of patients. And so they actually made very deliberate operational decisions based on the data. And then in January 2022, as that data as the virus concentration in the sewage started to decrease in the region, they started to actually reschedule some of these appointments and consider ramping up again. So this is one example of how this regional data can help make a very specific sort of local operational decision. I'm also going to zoom in a little bit just to show exactly how that wastewater data compared to clinical data over the course of that Omicron wave that we saw over the last few months. So this time series is a subset of, the MWRA Deer Island time series that I shared earlier, but it's bounded from December 1st through about mid-January 2022. And the thick line is the wastewater virus concentration, and the thinner yellow line is clinical cases as reported by a national database that we use. And what you can see is that this wave was very big compared to last year, compared to the peak that we had in winter 2020/2021. It was about 700 times as big as last year's peak. What you can also see is that wastewater actually had a very long lead time this time around, about 2 weeks, almost 2 weeks. Because you can see from the 1st of January through almost mid-January, the wastewater virus concentration was decreasing for almost 2 weeks as that clinical data, the clinical numbers were still on the rise. So this really drives home how the data can be this leading indicator. And finally, another thing that the most recent wave showed us is that at this stage in the pandemic, case undercounting, clinical case undercounting has gotten worse. And, there's many reasons for this. A few could be that the majority or a lot of folks are vaccinated. And so the disease COVID-19 is a lot more mild in individuals. And so people might not be seeking out clinical tests, or they might be asymptomatic. And so they don't even actually know that they're sick. And so they're not seeking out testing. They're not being counted and reported in these official numbers. It could also be because, we have a much greater access to antigen tests, at-home tests. And so people are testing at home and taking those test results, using those test results themselves to inform the behavior and not necessarily reporting the test results. And so again, that's contributing to this undercounting of clinical cases. And so as we progress through the pandemic, as we ramp down clinical testing capacity, and as antigen tests at-home tests become much more widely available, we think it's more important now than ever to implement wastewater testing really as part of our national infrastructure to help fill that gap. Wastewater data is becoming extremely complementary to the other sources of information that we are tracking. I also wanted to share that, the Omicron wave that we saw a couple months ago was not, a unique sort of situation. Wastewater data also reflected the Delta wave that we saw over the summer of 2021. And so what you're looking at here is data that Biobot has been collecting. The top 3 maps, data that Biobot has been collecting from sewage across almost all 50 states. And here we're aggregating the data at the state level. The darker colors are higher concentration levels, the lighter colors are lower. And you can see that we actually saw a ramp up in virus concentration from June through August that very much mirrored what we saw in clinical cases, which you can see in the bottom 3 maps. So the concentration really around the southern states in the country. And all of this information is available on our website. We put this information live online so that people can go and interact with it and leverage this information to make personal decisions around their own behaviors and risk tolerances. We share information at the national level. So this is a screenshot from today, actually, of where we're at in the pandemic nationwide. It really happy to say that sewage concentration levels today are lower than they have been since, early in 2021, at least since they've been in approximately July 2021. We also show wastewater the concentration levels by region on our website. So you can see the different regions in the US. We also show a breakdown of the different variants. So right now we are monitoring for the Delta variant, as well as 2 lineages of the Omicron variant, BA1 and BA2. So we are also posting this data on the website to look at the concentration of the different variants. And then finally, you can look at county level information as well. And that variant data is available at the county level also, right under the plot. So this here shows some of the time series, a screenshot of some of the time series that we have available for the state of Massachusetts. And zooming in on Suffolk County, Massachusetts, for the last 6 months, again, shows that the wastewater virus concentrations are lowest that they've been since September 2021. And so I'm going to end by just saying that, this is just the beginning. And I think if, one of the outcomes of having gone through the COVID-19 pandemic should be, as a nation, a renewed investment in our public health infrastructures. And that really wastewater epidemiology should be one of the core pillars of our national disease surveillance infrastructures. Because beyond COVID-19, beyond opioids, we can build dozens of applications with this platform, expanding into other infectious diseases, respiratory illnesses, and also biomarkers, like I mentioned earlier, like stress. And so with that, I'm going to say thank you and pass it over to John.
Great, thanks so much, Newsha. Let me just share my screen. So I'm coming here with a different angle on, I think, some very obviously similar questions. I have no expertise at all in wastewater, and so any questions certainly on that should go to Newsha. I'm coming with my public health hat on, and also as someone who by background has done a lot of work doing exposure and health risk modeling in a decision context and trying to think about what kind of information that we would like to have to make better decisions to protect public health. So over the course of the pandemic, I've become a consumer of the wastewater data, really just trying to understand what it tells us and how we can utilize it. And so I think some of the things I'll say will probably intersect with and overlap with things Newsha said, but hopefully offer a slightly different take and slightly different perspective that could lead to some good conversation. So the question that I want to ask and that I'm grappling with these and other data is, if we want to make on-off public health decisions. So right now, we're in a phase where we're removing mask mandates, we're sort of pulling back some of the public health requirements that have been in place because we're in such a good place, as Newsha alluded to. Like, what data should we use to make that decision so that we are data driven? And the flip side, if we see another wave, what data should we use to allow us to decide to put things back? And where do wastewater data fit into the equation? And so the two things that I want to keep in mind that I think, again, Newsha's talk foreshadowed. I mean, the first is that the past is not necessarily prologue. So we can't rely on the data or the insights that we used in the past because things keep changing in the pandemic, both the variants as well as the infrastructure that we have to try to deal with the variants, whether vaccines or antivirals or at-home testing or anything else. And and for infectious disease, the other theme, right, figuring out when to act is the key. Obviously, what we do to act is incredibly important, but the when is sometimes as important or even more important than the how. And I'll talk about both of these points as we go on. So in terms of data, this is a screenshot taken yesterday from the Mass Department of Public Health. And so these are the statewide data that we get on a daily basis. We no longer get them on the weekends, but we get on a routine basis. And this has really been the foundation of a lot of our conversations of where we are in the pandemic. I think for those who read the paper, a lot of this gets reported out on a daily basis. And what you can see here, again, this is a time series from the start of the pandemic to yesterday. the top left is cases. These are all 7-day average, so week average of cases. And then we have testing measured as percent positivity, hospitalizations, and deaths on the bottom. And so you can see a couple things just by the eyeball test here. I think one is certainly that the curves are not identical, but they follow fairly similar forms. And in particular, you can notice early on in the early months of the pandemic, we had very large burdens on hospitalizations and deaths. We all remember that back in March, April of 2020, very few cases. That's not because there weren't any cases, but that's because we did not have the infrastructure and the capacity to measure those cases. So this is not a true reflection of what was happening on the ground. We were really seeing, again, a horrendous burden in deaths and hospitalizations. The second bump that you see, which used to look like a huge mountain and now looks like a small hill after Omicron, is the Delta wave, where you can see things rising across the board on all the metrics. And then, of course, move on to the Omicron wave, where you see, by far the highest bump up in cases, and you see analogous bumps occurring in testing, hospitalizations, and deaths. And again, as Newsha alluded to, we are thankfully on the back end of that wave right now. And if you zoom in, this is the same Mass Department Public Health platform. This is just a zoom in looking at from Thanksgiving to today. You can start to pick out some subtleties that are hard to see with the 2 years of data. And in particular, you can see that the peaks are not happening at the same points in time. So, Newsha alluded to the fact that, there's a lag between when the wastewater data sees a peak and when cases show up. But you can see if you look at the cases and the hospitalizations below it, there's a lag there as well. And you can see as well, there's another lag when you get to deaths. And this becomes very important in thinking, how can we use each of these pieces of information to help us to make better public health decisions? So what I wanted to do briefly, kind of not presuming that everyone who's watching this has spent as much time obsessing on the data as I have, is to walk through what each of these things are precisely and what they do and don't tell us. So the first is the testing data, which is reported as percent positive, and sometimes this is confusing and people get confused that this says this is the percent of people who are positive with COVID or something like that, which is not what it is. It's really of all the tests that are reported to the state on a given day, what percent of those tests were positive. So it's a measure again of all the people who've happened to get tested at that point in time who was positive. And so there are some strengths of that as a metric, at least in the past, right? So one, if you look back at the prior slides, you could see in the past it correlated quite well with the number of cases. So as the percent positive went up, the cases went up and vice versa. So they tracked each other extremely well in the past, and it provided, as a result of that, a pretty good indication of just how much COVID is around. The limitations are multiple. I mean, one, the distribution of who gets tested on a given day is obviously not random. People are not just randomly getting tested. You're getting tested either because you think you might have COVID or you might have been exposed, or because you are at an institution like a university that requires you to test even if you're asymptomatic. And so the number has sort of started to lose its meaning over time. And in particular, if you go back to last fall, when the universities came back in person and many universities started very frequent testing of everyone on campus, at first the percent positive number was just reported out as it was, and it looked like the number was going down precipitously, which was wonderful to see, except that was because a lot of people with no symptoms and no exposure were getting tested. And so the state did eventually separate out the numbers for percent positive for universities and the percent positive for everyone else, but it sort of shows how the meaning of the number has changed over time, although at the main dashboard page, it still shows the aggregate. And now, with things changing again and universities likely starting to wind down some of that asymptomatic testing, in the coming months, we actually might now see the percent positive go up, but that's simply because there's less asymptomatic testing happening. Similarly, as Newsha said, as more at-home antigen tests are being used, it's less meaningful. So you might test at home, test positive, you might get a confirmatory PCR test or do something else so the data find their way to the state, but you might not. You might test positive, stay home, maybe you don't even interact with the healthcare system, and that positive test never finds its way into these data systems at all. So in terms of cases, I mean, that is fairly obvious. That's the number we're kind of most used to talking about. It's very interpretable. It's just how many people have COVID. And another strength is that if you're trying to make decisions about what to do, it tells you the likelihood of exposure. So if you tell me how many cases there were in the past week or two, I can say kind of what percentage of the population has COVID. And if you say, well, if I'm going to a room of 50 random people, how likely is it someone in that room has COVID? You can answer that question. That gives you either some reason to be concerned or some level of comfort, depending on where you are in the pandemic. So there's a lot of value of that information, but again, a lot of limitations. So, you know, if people are asymptomatic or very mild and are not engaging with the healthcare system, again, it may not be showing up, especially with at-home testing. And there's an active argument and debate, where there's people arguing on both sides that our societal goal should really be minimizing things like hospitalizations and deaths, and we should not be sort of as focused on cases at this point in the pandemic. I personally don't agree with that position 100%, but it is a limitation of the metric. And I'm putting here at the bottom, I'm going to put that for the next two, when Omicron peaked for each of these metrics. So across Massachusetts, the peak for cases was around January 8th. Again, it's a slightly different number than what Newsha was showing, which I think was the MWRA catchment area. So, but broadly, second week of January is when we really hit our peak for cases in Massachusetts. So if you go to hospitalizations, again, it is systematically ascertained. So we're picking that up through the hospital system. There's testing, there's metrics. We're certainly not missing people who are ending up at the hospital with COVID. So we're catching all those folks. If we're worried about the more severe outcomes, including the strain on the healthcare system, that is a good, robust indicator of that. But again, there are some limitations. One that has come up in a lot of debates and arguments is, are people being hospitalized with COVID or for COVID? Which again, I think is sometimes can be a little bit of a farcical distinction, but taken to an extreme case, if you're injured in a car accident, you come to the hospital and they test you for COVID, right? You are a hospitalization and a person who has COVID, and you are included in that data set. Clearly, that's not the reason you went to the hospital. It still matters, of course, because your healthcare providers need to know you're COVID positive so they can take the appropriate protections. We don't want transmission in the hospitals. We want to know how many people who are in the halls have COVID. So it's important, but it certainly differs depending on whether you were admitted for respiratory distress or the proverbial car accident and you turn out to be positive. The other sort of more profound limitations, again, it's not necessarily giving you insight about your exposure risk as a person. There's a subset of people who are more vulnerable who end up hospitalized. If I'm trying to figure out how risky is it to go someplace, the hospitalization number doesn't really tell me that directly, and it's a lagging indicator. So the Omicron peak for hospitalizations was on January 19th, so this is about a week and a half after cases peaked, which makes sense. When you test positive, you're not immediately rushed to the hospital. Usually there's a progression of the disease, and it takes a little while before you start to get sick. Deaths are the final metric. Again, those are very systematically ascertained. We're capturing that quite well with detailed demographics. And it's kind of a side point, but in trying to understand health disparities, it's important to know things like the race, ethnicity of the individuals who are infected. For deaths, that's ascertained for almost everyone. There's a lot more missing information for cases or even for hospitalizations. So we can know better the disparities without missing information. And obviously it's an important metric of what the toll of the pandemic has been on our society. But of course, as with hospitalizations, you're missing a lot of what's happening on the ground. You're missing all but the most severe outcome, less insight about exposure risk, and an even more lagging indicator. So again, the Omicron peak for deaths showed up on January 24th. And again, there's nothing surprising about the fact that hospitalizations lag cases and deaths lag hospitalizations. But it obviously matters for how we might use that information to make decisions. And B, it is something that in the public discourse seems to surprise people every time it happens. I think partly because we just tend to be consumers of real-time information. So, as Omicron was sort of peaking in the second week of January and hospitalizations weren't rising, there was a lot of public discussion about, oh, this is clearly mild and hospitalizations aren't going to be affected. The ratio of hospitalizations to cases was certainly lower for Omicron than for Delta, but it was profound, and the peak for hospitalizations was actually higher for Omicron than for Delta. And so each time when there's a week or two lag, we seem to be surprised as a society when that happens. So back to the wastewater data, I'm not going to belabor this because I think Newsha really hit these points, but it has considerable strengths. It's a leading rather than lagging indicator, which is profoundly important for public health decision making. Right, captures everybody. We don't omit the at-home testing again that's already been talked about. There's not a lot of limitations, but just to flag them, although 30% of the population is captured in 50 states, which is fantastic. It's not available for every place, so we don't have 100% population coverage with the data, though certainly we have metrics that represent all different geographies and confer quite a lot from that. And if we're trying to align everything perfectly, it takes some work to get the geography lined up. And I admittedly fell subject to that as well by comparing the Omicron peak for the MWRA region with the case peak for all of Massachusetts. And that's not a perfect alignment. The data that Newsha showed from Biobot has the geographic alignment, so it's a better representation of the lag. But Omicron peak in the MWRA region showed up just after New Year's. So just kind of a few more slides to wrap things up. Last week the CDC came out with their new guidance for how we categorize counties as low, medium versus high risk. There used to be a different metric which was principally based on case counts. By that metric, basically the whole United States was still represented as at high risk. And so this new metric, for better for worse, has led to a differing distribution. But it's noteworthy that there's a few indicators that are driving that assessment. On the far left, you can see cases are a part of that. So how many cases per 100,000 people in the last week. But then really what puts you into the high risk bucket is the hospitalization data. And there's two versions of it here: new admissions per capita and the percent of staffed inpatient beds occupied by COVID patients. So just two different manifestations of hospitalization data. And you can see the metrics that put you in the high risk. But that means that a community or a county would sort of be triggered into being high risk in general based on hospitalizations. And so as a lagging indicator, that's a problem because you may not be reacting quickly enough to really make a difference. So just to make it concrete, right, Omicron, we all know, highly infectious, incredibly fast spike and then incredibly fast decline. In the early days, it looked like the doubling time was 2 days. That means case numbers are doubling every couple days. So a 2-week difference, which in a lot of public policy, we say, well, what, if you pass this legislation 2 weeks later, it usually doesn't make a whole lot of difference. Here it does, right? So 2 weeks is 7 doubling time. So if you were dealing with 10 cases, now you're talking about 1,280 cases, right? 100 cases becomes more than 12,000 cases. So if you're waiting to see what happens with hospitalizations, you may be way too late to act. Now, you may not obviously wait for the peak of hospitalizations to act, but these thresholds are high enough that a lot would have happened prior to that moment for action. And so the value of the wastewater data in a decision context is that you can act much more quickly, much earlier, and there could be a profound difference. And just as a point here, right, you can look at the level, but you can also look at the slope, right? And when we saw that, again, eyeballing the wastewater data, when things are going up like a rocket, that things aren't good and that we need to start to take action to try to bring that curve down. So just to kind of wrap things up and transition to maybe some Q&A, I mean, I definitely endorse the idea that wastewater data can play an absolutely crucial role in early detection and hopefully prevention of future COVID waves. So that obviously should be our intent. We're pivoting into the next phase of the pandemic. I think anyone who projects precisely what that is going to look like is probably foolhardy. I don't know what the summer, fall, and winter upcoming are going to look like, but what I do know is that if we're able to act early, we can act with a focused and targeted response that will have better public health outcomes and much less disruption. If you wait until you're too late in the game, then you often have to take far more aggressive and wide sweeping action. So I think the ability to be targeted, precise, capture waves early and dampen things down, I think would provide tremendous value. And there's many versions of this last quote that, this was just one that I found, and I don't know what the original one is, but essentially the goal of public health is often to have nothing happen. And another version of it is basically, when public health does our job, then people complain that we've done too much because they say, what's the point? Nothing happened. So my hope would be that, come this fall, we see wastewater tick up, we take public health action, nothing happens, there is no wave, and people complain that we overreacted, but we will have saved lives as a consequence. So I will stop there. Happy to answer questions.
Thank you both so much for making this topic so very accessible to those of us who are lay people in the public. I do have some questions for you, so why don't we just get right to those? One question is, why do you think the BA2 variant of Omicron is higher in Suffolk County? I guess the data showed that it was 15.8% than in other Massachusetts counties.
Yeah, that I was just referencing that. So I'm not sure, actually. I'd be curious what John thinks in terms of other like public health factors, but it could be that it has to do with the density of the city. It's a more highly trafficked region as opposed to other counties in the state. And so naturally, there's just more transmission happening in these urban centers and cores. And so I think that maybe could be one way of looking at it. But yeah, curious, John, if you have any thoughts there.
Yeah, and I don't have a clear answer to that other than in a lot of the waves, things seem to kick off in major urban centers first, maybe because there's more international travel and sort of more cross linkages with other places. And so certainly, right, BA2 is kicked up in a host of different places around the world. Denmark had a huge wave. I think Hong Kong is seeing it now. So there's a lot of different places. And certainly if you're a hub of international travel, it just may be more likely to cross through. Eventually, it finds its way everywhere, as we've seen each and every wave. But again, going back to the beginning, things were really kicking off in New York City, and probably a little bit less detected in Seattle, but with a kind of a major set of cases there. So it wouldn't be too surprising if there were to be a BA2 wave, which is of course an if, that it would start in some major urban centers with a lot of international travelers.
Mm-hmm.
Okay, thank you. What is the significance of the lag between the wastewater data and clinical cases? That is due to asymptomatic cases or people shedding virus before they are sick enough to get tested, or something else?
Yeah, I'm happy to start with that one. So, we think that a big contribution to the lag between wastewater data and clinical data actually comes from our testing practices, as opposed to very significant, let's say, differences in shedding behaviors. So, for example, if somebody feels sick, by the time they seek out a test, maybe they're only getting the test on day 3 of feeling sick. And then there's a lag in that test getting analyzed and the data being reported back and actually being tracked and logged up at the reporting level. And so that when you start to aggregate all of those kind of components together, that's when you start to see the lag. Now, there's also a thought that maybe we are actually shedding the virus in our stool before we become symptomatic. But even if we were to shed at the same time as developing symptoms, just purely based on the behavior around getting a test, that inherently presents a lag.
Yeah, no, I 100% agree. And just to amplify the point, I mean, I think anyone who is trying to get tested, right in early January, recalls that there were sometimes 3, 4, 5 day lags to get in someplace, and so the infrastructure was overrun, and so you had plenty of people who were sick and not getting tested for some period of time, which again reinforces the value of the wastewater data, right? In particular, at a time where our systems and our structures are not adequate to test everyone rapidly and sufficiently, and so we're missing out on a lot of what is happening, or we're getting a delayed response by relying on the testing data.
Mm-hmm.
Okay, thank you. Thank you both. Beyond SARS-CoV-2, what do you think are the most important targets to monitor in wastewater?
Mm-hmm. Yeah, so I already mentioned influenza, and that's something that our team has been working on. And so we have been actually analyzing for influenza A and B in samples. And I think that also really demonstrates the value of wastewater epi for something really as alarming as COVID, all the way through to something as, pervasive and endemic as influenza. And the value there becomes, imagine every year in flu season, a local community knowing, even just getting a day's worth of a heads up on when the influenza surge is going to kind of hit their clinical systems. John showed what just a 2-week, lag or heads up can do in terms of COVID cases, 10, at least during Omicron, 10 turning into, approximately, I think it was 1,000. Think about similarly with influenza, it might not be as something as threatening as COVID-19, but operationally, our hospitals can prepare, or our clinical centers can prepare. And so we see influenza as really being like one of the obvious targets, and one that we're going to be launching more widely next influenza season. Of course, the opioid work that we had been doing prior to the pandemic, which we're actually now bringing back more as high-risk substances as opposed to just narrowly focused on opioids. So it is including other drugs of concern to public health agencies like methamphetamines. And so high-risk substances, and, I think the tremendous value there is that the data is really enabling public health agencies to shift from looking at only overdose deaths as the metric by which they evaluate the severity of the opioid epidemic in a community, to looking at consumption via wastewater. Of course, that's the equivalent of looking at hospitalizations or deaths versus cases. And so we should really be designing our interventions, our substance use disorder interventions based on consumption, not just using death data. And then also moving into other infectious diseases like hepatitis C, other respiratory illnesses. I think another big potential for wastewater epi to make an impact when it comes to global public health is looking at antimicrobial resistance. So antimicrobial, antibiotic resistance bacteria, and how we can leverage the data to actually get a better understanding of antimicrobial resistance within a community, and how that data can feed into decision making.
Want to add anything to that, Dr. Levy?
I can't add too much other than just a parenthetical that there's, in the environmental science area, there's also been a lot of interest in understanding pharmaceuticals in wastewater, in part because of part for surveillance, but actually in part for the ecological consequences of that, effects on marine life and so forth from all the things that we either dispose of or excrete into the the sewage system that can actually then find their way to, depending on how well it's treated, find a way to affect ecological health. So there's all sorts of different ways that, data from wastewater could be informative and valuable.
Great, thank you. Thank you both. How many people shedding virus are needed to lead to detectable levels of virus in wastewater? That is, how sensitive is the wastewater sampling?
So how many people are needed to be shedding to be able to detect?
I guess how much volume do you need?
So we, our methods are sensitive enough to detect one infected individual in a group of about 6,000. So if we get smaller than that, then we can definitely detect an infected individual, because the smaller the population size gets, the more similar the sample becomes to a stool sample. So one person takes up a much larger fraction of 1,000 people as they do 6,000 people. So once you get into larger communities like the MWRA system that represents about 2 million people, then you need a much larger number of individuals to be shedding for us to be able to, for the virus level to go above our limit of detection.
So do you have a sense of what that number or percentage is that you need?
So it would be, off the top of my head, trying to do 2 million divided by 6,000. I'd say we're like, just the order of magnitude that we're in is in the thousands of infected individuals.
Thank you. Is it possible to make predictions about the future of the pandemic based on, all the data that you've seen so far?
Yeah. That's a great question. And I think one of the things that, I think there's tremendous potential for us to look at wastewater data together with all sorts of other data. So some of the data that John was sharing, but then also other information, and be able to understand what was the relationship between the wastewater data and some of these external data sets. And so moving forward, how can we start to actually build predictive models, leveraging the wastewater data together with other data sources? So there's definitely a lot of work to be done there, and a tremendous amount of potential. And at Biobot, we are ultimately a data analytics company. And so data analytics, data science is very much like core to our work and what we do. And so that's, a direction that we'll definitely be growing in.
Yeah, no, just to briefly build on that, I think, folks in public health have, I think, sometimes been susceptible to trying to model too much or too far out, and maybe assuming that, again, the conditions of the past will always predict the future. And I think people with good memories can recall, right, models that were put out back in April or May of 2020 that said the pandemic will basically end by August of 2020, and so everyone just sort of fit a curve to the first few months and said, well, here's the peak, and then we will hit the decline, and then it will be over. And so those models, of course, didn't anticipate new variants or different modifications. And so I think where really the power lies is not as a crystal ball of saying can we use these data to predict what March of 2023 will look like. No, we can't. I think nobody could. But can we use a composition of data to have a much more realistic sense of where we're going to be in a few weeks, in a month or two, and have a better sense using a variety of early indicators that can allow us to know if things are shifting, right? And there's again, the wastewater data is a big part of that. Other people have used Google search term data, a whole host of other data that have been shown as kind of leading indicators of future cases. And, I think we can get a lot smarter, whether using big data methods or other things, to pull all these data sets together and to be able to at least say, okay, something's changing, right? We're not following the same path we were on before. There's something that's changing. We've got to start to pay close attention and maybe start to take preventive action.
Thank you. Thank you both. We are getting close to 8 o'clock, but there are a few more questions. So just try and keep that time frame in mind. One person wants to know if your raw data is available to the public.
Yeah, so on our website, you'll be able to see when you scroll all the way to the bottom. On the left, there's a section that says interested in seeing the data, and there's a see data link there that goes to our GitHub repository where the data that is being visualized on the website is available.
Excellent. Great. Is it possible that the shedding levels are different among the various strains? And if so, how would you recalibrate?
Yeah, that's a great question, and one that we've been asked a lot and that we've looked into, but so far we've had no evidence to really think that shedding has changed dramatically variant to variant. And if anything, given the population size at which we are monitoring and analyzing wastewater, we think that at that point, it tends to average out, and any sort of discrepancy between individual level shedding essentially becomes smoothed out to be negligible. So to date, we have no evidence to think that differences in shedding is significant enough to present any sort of, significant change in how we should be interpreting the data.
Okay. I think this is probably our last question, asking about your back of the envelope math calculation, Newsha.
You might be wrong.
Wouldn't the math mean that you could detect 334 infections because 2 million divided by 6,000 is 333.33?
Yeah, so that would mean that we would need a minimum of that 333, I guess. We would need a minimum of 333 individuals to be infected with COVID-19 in order for us to be able to detect SARS-CoV-2, to actually be able to detect the RNA in our lab.
I think that's a good place to stop. And I want to thank you both again for your time tonight. This was a fascinating topic and discussion. And I want to thank all of you for tuning in, and have a good evening.
Thank you.